Hello, my name is Monica Lee, and I'm a lieutenant in the Navy Nurse Corps. Today I'm going to discuss skill retention challenges for Navy critical care nurses, particularly in the low acuity military treatment facilities, and how high fidelity simulation may help address gaps in clinical exposure, readiness, and management of high acuity patient situations. One challenge in military critical care nursing is that many MTFs manage relatively low acuity patient populations and may also experience low patient census at times. While nurses may successfully complete orientation and annual competency requirements, they may not frequently encounter high-risk situations such as rapid deterioration or shock requiring vasopressor support. Over time, limited exposure can contribute to skill decay and reduces confidence in managing these events. Clinical experiences can also vary significantly between the MTFs, which creates differences in knowledge, skills, and abilities across the workforce. Specifically overseas, the ICUs are not truly treating ICU patients unless it's Guam. Oftentimes, it's a closed unit or it provides lower acuity patients such as telemetry. In the CONUS MTFs, it's often an issue as well, still with low census and low acuity, even though we have some trauma centers. And funding for skill sustainment to train elsewhere is an ongoing issue if you're overseas. This is a recognized problem within military nursing, and many experienced ICU nurses report frustration with limited opportunities to maintain critical thinking and high acuity clinical skills after entering the military. When critical patient situations do occur, nurses must be prepared to recognize deterioration and intervene appropriately to support the best possible patient outcomes. And limited exposure to these situations can impact confidence, timely decision making, self-efficacy, and overall clinical readiness among critical care nurses. Skill retention is important because high acuity patient situations often require rapid assessment, prioritization, and quick intervention. Delays in recognizing deterioration or initiating treatment can negatively impact patient outcomes. This is particularly important in military nursing because nurses assigned to lower acuity MTFs may later deploy or transition into environments with significantly higher patient acuity and operational demands. In addition to technical skills, confidence and self-efficacy also play a major role in clinical performance. Nurses who rarely encounter critical situations may feel less prepared to manage these events independently when they occur. Because of this, maintaining readiness requires more than initial orientation or annual competency completion. It requires ongoing reinforcement and exposure to high-risk clinical decision-making. This is important in deployed or austere environments where resources and specialty support may be limited. A colleague shared an experience from a deployment where an ICU nurse and an orthopedic physician were managing a patient presenting with a medical issue, and although the physician was highly skilled within their specialty, they were less familiar with critical care management of the condition, so the ICU nurse's knowledge and clinical judgment became extremely important in that circumstance. Experiences like this highlight how maintaining critical care knowledge, skills, and abilities is essential, especially when nurses may be practicing in environments with limited staffing, limited specialty coverage, or increased operational demands. Critical care nurses develop strong bedside assessment and prioritization skills, but the skills must be reinforced over time in order to maintain readiness and support optimal patient outcomes. Currently, many ICU nurses complete an online training program called Essentials of Critical Care Orientation, or ECHO, created by the American Association of Critical Care Nurses. There are different ways organizations incorporate ECHO into orientation, including preceptor simulation and pacing of course modules over time. From my experience, high fidelity simulation was not integrated into ECHO training, even though AACN recommends pairing simulation scenarios with each body system in course modules to reinforce the learning. Much of ongoing competency training in the military setting revolves around annual competencies and skills fairs. While these activities provide exposure and help to review a certain skill, they may be less effective for long-term skill retention when critical care skills are not practiced regularly. Occasionally, units provide in-services or bedside education, but nurses are often focused on patient care responsibilities and may not be fully able to engage in learning activities during clinical shifts. The civilian partnerships can help address gaps in exposure by providing opportunities to care for high acuity patients. However, these experiences are often opportunistic and limited by staffing and scheduling, and it's not consistently available to all critical care nurses. What are the advantages of high fidelity simulation? It offers an immersive and realistic learning environment where nurses can practice recognizing patient deterioration and managing critical events without risk to actual patients. Unlike online learning or annual competencies, simulation allows repeated exposure to high acuity situations and supports hands-on integration of assessment, communication, prioritization, and intervention skills. High fidelity simulation also supports experiential learning and allows participants to make mistakes, be able to reflect during debriefing, and apply feedback in a psychologically safe environment. In critical care settings, this can help improve confidence, clinical reasoning, and rapid decision making during high-risk events such as shock or rapid deterioration. What are the disadvantages? Although high-fidelity simulation offers many educational advantages, there are some limitations. Simulation programs require significant investment in equipment, maintenance, trained facilitators, and dedicated simulation space. Scheduling can also be difficult due to staffing constraints and clinical responsibilities. In some settings, high-fidelity mannequins may already be available, but they're not always used to their full capability. And from my experience, this can occur because of maintenance issues, inconsistent faculty training, turnover among instructors, or lack of standardized simulation curricula. These barriers can limit sustainability and reduce the effectiveness of simulation programs if not addressed during implementation planning. One example of high acuity, low frequency simulation scenario involves an ICU patient experiencing progressive shock and worsening hypotension. During the scenario, participants would be required to recognize signs of deterioration over time, assess perfusion status and hemodynamic instability, and determine whether the patient is responding appropriately to interventions such as fluid resuscitation. The case study would unfold based on how the nurse tends to intervene. As the patient continues to decline, participants must identify the need for escalation of care, initiate vasopressor therapy, and communicate with the healthcare team and prioritize interventions in a time-sensitive environment. This type of unfolding scenario allows nurses to practice critical thinking, rapid decision-making, and management of physiologic changes that may not occur frequently in lower acuity military treatment facilities. High fidelity simulation has the potential to support long-term sustainment of critical care knowledge, skills, and abilities among Navy nurses assigned to these lower acuity military treatment facilities. Rather than relying primarily on initial orientation or annual competencies, repeated simulation exposure may help reinforce clinical reasoning, confidence, and rapid decision-making during high acuity patient events. There's also potential for simulation-based sustainment programs to become more standardized and scalable, across the MTS, particularly for high acuity, low frequency events that nurses may not encounter regularly in clinical practice. This approach aligns with broader Defense Health Agency priorities related to workforce readiness, patient safety, and maintaining clinical competency in operational and austere environments. Overall, simulation should not be viewed as just a tool for initial education, but also as an ongoing strategy to support readiness and sustain critical care competency over time. Not just for nurses, but all healthcare providers can benefit from high fidelity simulation that allows for a case to unfold based on response and initiation of treatments. These are my references. Thank you for your time.